Good afternoon, the diseased and the healthy. My name's Danny Whitaker, my own worst enemy, mental health podcast. I'm not going to stick around too long. Listen to my voice. I have the man flu. My eyes are watering, got a sore throat, snotty, sitting here with tissues stuffed up my snout, like I've got a nosebleed, got a headache, dry mouth, can't sleep at night because of it, dreaming about eating sand, the works. But here I am, nevertheless, despite these rancid afflictions, dragging myself into the recording booth to make sure I get this episode published, just so you geeks have something to listen to over the weekend. That's commitment. Speaking of man flu, something I want to get off my chest, aside from the obvious. Right, when people hear the term man flu, I think they tend to sort of interpret that as a sort of mocking allusion to this horrendously sexist idea that men can't handle being ill. However, allow me to posit the following evidence in favour of man flu being a genuine medical phenomenon. Now, this is from The Independent, Wednesday 14th of December 2016, and written by a woman, no less, Katie Forster, just in case you have the audacity to assume any sort of gender bias. Headline: Man flu could be real after all, scientists say. Right, get this. Some infectious diseases have evolved to be more harmful to men than women, a new study has found, suggesting those who scoff at so-called man flu may have to think twice. Certain viruses may go easy on women in an attempt to be passed on to children through pregnancy, birth, or breastfeeding, according to researchers at Royal Holloway, University of London. This means men could be hit harder by the infection and can suffer more severe symptoms of any resulting illness. So, there you go. It's official. Man flu is real. And like I say, that's not from some crazy meninist blog. That's from The Independent, a mainstream newspaper over here in the UK. And we all know the mainstream media never talks bollocks, so it must be true. Right, anyway, the topic of today's conversation is maternal OCD. My guest today is Dr. Fiona Challacombe. Fiona is a research fellow and clinical psychologist working at the Maudsley Centre for Anxiety Disorders and Trauma and at the section of women's mental health at King's College London, where she specialises in maternal OCD and anxiety. She is a patron of Maternal OCD, which is a voluntary organisation dedicated to raising the profile of obsessive-compulsive disorder for mothers. And, along with Professor Paul Sarkowskis, who we've had on a previous episode, she is co-author of Break Free from OCD, Overcoming Obsessive-Compulsive Disorder with CBT. In today's episode, we explore how and why OCD manifests during the perinatal period, the nature and content of the obsessions and compulsions, what causes maternal OCD, is it down to hormonal changes, living in a risk-averse society, or just the evolutionary desire to keep our children safe from harm. We explore why maternal OCD is given such little attention compared to other mental health issues, whether or not this condition has long-term ramifications for the children of parents with OCD, and, most importantly, how to seek treatment. You can follow Fiona on Twitter. She's at Dr. Fiona CH. That's at Dr. Fiona CH. As always, if you'd like to comment on this episode, you can do so by going to myownworstenemy.org/podcast. That's also where you'll find all the show notes and any relevant links. Right, anyway, I'm off to go soldier through this man flu, and a level of suffering, it turns out, that no woman on this planet could ever appreciate. I'm joking. I've sat through 2 labours, the first one like 36 hours. Never have I been more appreciative to have been born male. You girls are hardcore. Anyway, as I always say, please enjoy my conversation with Dr. Fiona Challacombe. Okay, Fiona Challacombe, thank you for joining me. Welcome to the podcast.
Thank you for having me.
Okay, today, bit of a niche one, this, I suppose. Or maybe not, we'll find out. We're talking about maternal OCD. I think, okay, before we jump into the definitions, I'm very confused with some of the terminology to do with this. I always like to start off by, you tell me a little bit about yourself, your history, how you got into this particular field, and why this is of interest to you.
Okay, so I'm Fiona Challacombe. I am a researcher and a clinical psychologist specialising in maternal anxiety disorders, and I've done a lot of work in maternal OCD. When I was training as a clinical psychologist, I worked with OCD, and I ended up doing my dissertation on parenting in OCD, and it was actually looking at mums who had slightly older children, and I was looking at how the OCD kind of impacted things at home. But I was really struck by how many of them said, well, I was diagnosed with postnatal depression, but actually that's when the OCD started. And it was really, I think that was the OCD. It wasn't really depression. And at this point, this was about kind of 15 years ago, there was very little knowledge about OCD in the perinatal period, so around sort of pregnancy and birth. So although lots of people had heard of sort of postnatal depression, including these women, they were quite sure that there was something else going on. So I was really intrigued by this because it obviously hadn't been picked up, and their OCD had been around for a really long time. So I ended up following that as a research track, really. And in the sort of intervening time, there's been a lot more studies looking at it. So it's kind of really developed as an area. Sort of, we've got a better understanding that lots of disorders, of course, can be triggered by pregnancy or exacerbated by pregnancy in the postnatal period, and that we really need to be looking out for more than depression, although that's a very common problem, so that people can get the right treatments. So that's how come I got involved in this area, really. And I work in a specialist clinic for anxiety disorders, or a national centre for anxiety disorders. So obviously within that we see the whole spectrum of anxiety disorders, and they're all present and have particular implications for the perinatal period. So that's how my interest has developed, and I'm pleased to see that the knowledge and interest in the area as a whole has also developed in that time.
Right, I think a good place to kick off would be with the terminology. So all the little bits of reading I've done, we've got prenatal, perinatal, postnatal, and then we've got like postpartum as well. I'm not sure if they're just like an Americanization, but if you could pass those terms up for us to start with, and what period exactly they are referring to.
Yeah, it's really confusing. There are lots of overlapping terms. So here in the UK, we say perinatal has a specific meaning, and it means that the time of pregnancy and up to the first year after birth. So that's perinatal, covers all of that. And then we would say antenatal for obviously or pregnancy, and we say postnatal for the time after the baby has arrived. But that's also the same as the postpartum, and technically you might say antepartum. But here the main terms are perinatal for the whole lot, antenatal, postnatal. That's what we tend to use here. Does that clarify it a little bit?
Yeah, it does. Well, it just so we can kind of establish the definitions moving forward that I'm going to use. Because I'm interested in whether or not, I mean, we'll get to this, but whether there's like the specific content of the obsessions and compulsions during pregnancy as opposed to after pregnancy, because I'm assuming in advance that those are the content is going to be different. The next thing is, I'm talking to the listener now, if you want to dig a bit deeper into OCD specifically, me and Paul Sokovskis did like an hour and 45 minutes on that. I think episode 4, you can go back to that. However, I would like to kind of, to a certain extent, assume no prior knowledge on the part of the listener. And if you could give a kind of a brief summary of what it means to have OCD and differentiate it from the kind of, what's the term I'm looking for here? the term that kind of the general public use when they've just got a preference for something or a bit of a hobby with something, and they term that as being OCD. So if you could separate those out.
Yeah, absolutely. So it is a term that's used a lot these days, isn't it, for kind of quirks or liking things in an orderly way. But OCD, of course, is not that. OCD is a disorder that impairs people's functioning. So it's typically sort of broken into those three parts. It has obsessions, which are unwanted, intrusive thoughts that things might be wrong or something bad is about to happen. And compulsions that are there in order to try and reduce the feelings of anxiety or to stop something terrible happening. And the really important aspect of the diagnosis is how much this is impairing people's functioning. So to get a diagnosis, it's bothering you for at least an hour a day. And for most people, it's bothering them a lot more than that with a clinical diagnosis. So it's a serious mental health problem that's very far from quirks and things like that, which often people find helpful. They don't, impact in people's lives. So it's a very important distinction.
Right. Okay. Before we kind of get into the thick of it, I think a good place to kind of get started with this is to kind of paint a picture of paint a picture of the type of person that's likely to go through this. And I think a good springboard for that would be if you could possibly give us some statistics, some like basic epidemiology of the mums that are likely to go through this.
Sure, yeah. It's interesting to say sort of type of person, because it probably isn't easy to sort of categorize a type of person, but we've got a better understanding that it's much more common than we thought, really. So probably we think in the general population there's about between kind of 1% to 2% of people who have OCD. My reading of the epidemiology is it's probably quite similar during pregnancy, but actually postnatally slightly more common. Looking at all the studies together, we think it's probably more like 2 to 3% of people actually have a clinical problem. This is mums in the postnatal period. We don't know so much about dads. That's an area that needs a lot more attention. We know it's possible for dads to develop OCD as a result of their partner's pregnancy. That definitely is in the case literature. That definitely happens. But we're much less knowledgeable really about what happens for dads and what's going on there.
Okay, let me run a couple of like speculations past you and see if you got anything on this. I was wondering if there was any difference between younger and older mums.
Again, this might be slightly more common in first-time mums, but it's certainly not a problem that's confined to new parenthood. So if you think, it's literally just a sort of Venn diagram of OCD and having a child. Sometimes it's triggered by the pregnancy and the postnatal period. Other times it's not kind of specific to that. They just happen to kind of go along together, or it might be unrelated to the pregnancy and the child. So there's lots of sort of possible routes to it. So I think for some people it is a specific trigger, and they can have unwanted thoughts that they weren't kind of expecting or know about, and they can interpret those thoughts as meaning something awful, and that can be a really kind of, the pregnancy is really, or postnatal period is really sort of specifically the trigger. For other people, they've had other stuff kind of going along beforehand, and actually just sort of being pregnant and the responsibility and so on, it just adds another sort of dimension of difficulty, and the problems sort of arise there. So they might already have other children, and the OCD can also kind of morph types as well and change types. So there's all sorts of different sort of routes which are possible. But I think there probably is a subgroup, as you're suggesting there, of kind of mums who are going through it for the first time. I'll just talk about mums, given that we don't know so much about dads, for whom it is a specific trigger. And there's some really interesting research looking at kind of pre-existing beliefs about thoughts can predict symptoms. So there are probably some vulnerabilities in terms of kind of beliefs and so on for a particular group.
Yeah, another one that I was wondering about is whether single mums would be more susceptible. And the reason I ask that is, I imagine that the kind of the anxieties that come with being a mum if the father's present, it's a shared responsibility. And if you're a single mum and it's solely up to you to look after the child, make sure the child's okay, I was wondering if the pressure of that would make it more likely to arise in single mums. I mean, that's obviously pure speculation on my part, and I'd just be interested to know if you knew anything about that statistically, say.
Yeah. I think, to be honest, the majority of people who take part in research probably do have partners, actually, thinking about the studies that are out there. So it's hard to answer that question, but I think lots of mums, it would probably sort of resonate that, particularly in the early stages, they kind of do actually feel very responsible. So the difference between being a single mum and a mum with a partner in that sense might be quite kind of subtle. I guess, obviously having people around and social support we know is a big kind of factor, but in terms of kind of the stress of the whole perinatal period for everybody. But actually thinking about the research that I've done, lots of the mums, even with partners and people around, would say that they didn't actually feel supported and so on. So there's something about the sort of isolating effects of the disorder that does make you feel responsible, I think, slightly regardless of who else is around. But in answer to your specific question, I think we don't have enough data on single mums, and I don't think anyone's looked at the difference there. But it certainly, again, is not confined to mums without partners.
Yeah, well, I guess that kind of relates to my next question. Really, is with things like depression and anxiety, the research is so comprehensive and goes back such a long way. I mean, even the average person can go on Google and look at different graphs and figures and demographics, and you can really kind of pin down some really interesting correlations between things like socioeconomic background, ethnicity, religious beliefs, all kinds of things. Whereas I suppose these questions I'm throwing at you now, and you're saying we haven't got the data to kind of seek out these correlations. I suppose my question relating to that is, why has this topic only recently come to be studied? I mean, even when you go out, when I was doing the research for this interview, hardly any material out there. There's a few specialist websites, but it's not, it's not a widely known topic. So I'm just wondering why it's only recently come to light.
It's a good question, I suppose, in terms of kind of resources. I think it probably took a really long time to get, mental health into the sort of perinatal agenda at all. And then it was, quite rightly, lots of focus on depression. That is the most common mental health problem. As I say, I think it's only kind of really filtered through in the last sort of 15 or so years about the importance of looking at the whole spectrum of disorders. And I think as we've probably got better, primary care treatment accessibility as well, that's probably kind of related to things being more on people's kind of radar, the idea that it's not just depression. But yeah, I think it takes a long time for kind of research interest then to sort of filter down into practice as well. So in terms of the resources that are out there, as you say, it is still kind of minimal. My sense from talking to women is, people don't get asked about these things kind of routinely. There's still lots of problems with diagnosis and that kind of stuff. So there's still lots of work to do.
I know this is purely speculative, and just be interested on your opinion on this, again, speculatively. I was wondering if it was, the reason it's come to light now, more recently, is I was wondering if it was maybe possibly almost a new phenomenon, in that, I guess, with the nature of OCD being what it is, I mean, we'll get to these in a second, but just in general, you've got things like concerns about contamination, harming somebody, or in this instance, harming the baby, either accidentally or on purpose. And I was just wondering if it seems that our generation is very germ-phobic, and in the news it's just violence and people are dying left, right and centre, and there's all kinds of catastrophes going on around the world. And I was just wondering if possibly maternal OCD, I guess it's probably always been there to an extent, but whether it's maybe on the rise because we live in an environment that kind of emphasizes caution so much, and maybe that exacerbates those kind of worries in the minds of the mothers. And again, it's purely me speculating, but I'm just wondering whether you think there's something in that, maybe.
It's hard to say from the data that we've got. I mean, as I say, my starting point from this was talking to women for whom it clearly had been around for ages, but the ability to recognise it just wasn't there. They didn't know what was going on when they had their children, and professionals were a long way from asking them about it. So to me, that kind of suggests that what's changed mostly is that people have more knowledge now, and there's better sort of disclosure. I think there are specific things, like when the bird flu sort of pandemic was on the horizon. I think, pregnant women, there was a specific risk to them, so they were kind of more worried about that. But I think in general, there isn't a simple relationship between the sort of the threat of the time. There's always stuff going on, isn't there? And it's hard to sort of trace that in the sort of epidemiology. But partly we don't have brilliant sort of studies. But I think there's always an element of people who feel sort of susceptible to threats. And I think one of the most sort of common forms as well of maternal OCD is the sort of worry about harming children. I think that probably has, we know that the sort of focus of OCD can change with the kind of preoccupations of the time. So I think it's the focus rather than the prevalence that changes, but certainly much more people these days are worried about, say, being a paedophile. And I think that's a sort of result of how our sort of societal preoccupation with that, I think, as well, that being the worst possible thing that people could imagine. So that's a really common form of maternal OCD. And I think that theme is probably more common than it was previously. But kind of from what we can gather about looking at studies of OCD in general, the prevalence is relatively consistent over time, I think.
Do we know, is there any kind of basic divide between East and West, Western culture and non-Western culture? Have we got any figures on that at all?
Yeah, there are some really interesting sort of global studies. And again, interestingly, the prevalence is quite consistent across countries, apart from Taiwan, which has a suspiciously low prevalence. I don't know.
Oh, right,
okay. But yeah, it seems to be at that sort of 1 to 2%, although the content tends to differ. So in more kind of Islamic countries, for example, you get more religious types of OCD and preoccupations. So it makes a good case for the sort of societal influence, really. But actually, the data seems to show relatively sort of consistent across all different types of cultures.
Right. Okay. What I'd like to do now is we've kind of dipped in and out of it, but I really want to explore the kind of the nature of both the obsessions and the compulsions that a mum's likely to experience. So I think we'll start with, we start with the thoughts and then get into the kind of the behaviours that are gonna result from this. So what are some typical obsessions, themes, thoughts that are likely to arise? And is there any kind of interesting difference between I'm going to try and get this right, the prenatal phase and the postnatal phase?
Yep.
Yeah, got that right. Yeah. Okay.
Yeah, I mean, I do want to emphasise though that any form of OCD is possible in both phases. So there certainly are things which are more common than others, but something that can really throw mums and professionals is when OCD is a real sort of chameleon, and you can get quite unusual things which are still OCD, and you can get sort of checking OCD, things which are kind of checking doors and locks, which aren't obviously related to the baby, for example. But yeah, all of these things are kind of possible within this period. So in answer to your question, though, certain things are, I think, more common. So what the literature shows is that prenatally, antenatally, concerns about contamination are more common, and also fears that the baby isn't yours. So in terms of sort of intrusive thoughts, those are quite common intrusive thoughts for people to have. And postnatally, the most common types would be probably number one, I think, well, from certainly in my studies, number one was kind of fears that you might harm the baby, deliberately or accidentally. Lots of people sort of worrying about deliberate harm. So am I capable of doing something awful? Oh my goodness, what have I did? How does this happen? Those kind of horrible ruminations, and lots of contamination related OCD as well. So those are probably the main types. As I say, all types are kind of possible. And there's a clear sort of context to this as well, because if you have been pregnant, there are lots of messages about sort of contamination and responsibility. It's a proper OCD cocktail, I think, during pregnancy. It's like, oh, you may do something or you may not do something that could impact your baby at some point in the future, unspecified. So in terms of those horrible worries, if you're susceptible, it kind of makes sense that people might kind of develop anxiety problems with those messages, and the advice that goes on, which is good advice, I think, about being generally kind of careful and clean. I'm not sort of disputing that, but for people who are already worried about those kind of things and feel very responsible, they can get very kind of worried about touching things or what they're eating and so on. That goes way beyond the guidance. So that particularly happens during pregnancy. And for some people, actually, their OCD can be kind of limited to pregnancy. So it is all about that. Obviously, you are kind of literally responsible when the baby is in utero. Everything is sort of mediated through you. And then for some people, it can then kind of resolve when the baby's born. But for others, they will get kind of equally then worried about kind of sterilization and contamination with babies' bottles. And again, it's something that we're kind of encouraged to do as new parents, to do all this kind of sterilizing. I think they come with tweezers and things, so you kind of got sort of an obsessional kit almost there. And there's no advice, of course, from the makers of these things about exactly kind of when to stop. And for most people, it sort of tails off and the babies start kind of putting things in their mouths anyway, and there's a sort of natural tailoring. But of course, if you're very worried about rules and the OCD, and you have an obsessional kind of problem, that might be really hard to sort of determine. So that's, people can get into lots of checking, and also sort of checking their baby kind of through the night. And there is this, I think there's a sort of quite a sort of a diagnostic cusp almost for people who are with health anxiety as well. So people who get very worried about the health of the baby and have lots of kind of intrusions about something terrible happening to the baby, and it's almost like a sort of health anxiety by proxy almost. So kind of checking the baby through the night, not sleeping themselves, really kind of checking them when they put them into the pushchair, everything kind of taking ages, take lots of visits to the doctors and so on. So it can kind of manifest in different ways, but those would be some of the typical ones.
Do you mind me asking, have you got children?
I do.
Do you see the seeds of any of these behaviours and thoughts yourself?
It was an extremely interesting experience to have children. This is a psychologist's answer, isn't it? I was observing myself, but I think it does bring to the fore how these things are possible. I think when you've gone through that experience yourself, and how difficult it is with the best resources in the world to kind of look after a child and kind of come to terms with that responsibility. But I remember having intrusive thoughts when my eldest was a tiny baby, and I can remember vivid intrusive thoughts and images of kind of smashing her. I think we had a little bathroom, and just imagining her being kind of smashed on the porcelain there, and I thought, oh, I'm having an intrusive thought, and I'm in the middle of my kind of PhD about this, and it's that doesn't mean it meant that I could then go, oh, that's interesting, as opposed to what does it mean about me that I'm having this thought. But it was a useful experience in that sense. I think, wow, this is kind of just what happens, and it did make me want to take even more care of her and so on. So, you get a kind of an insight into that spectrum of kind of how it can happen, how these thoughts are genuinely normal and probably in a perverse way helpful for the general population. It's how we've kind of survived. We're kind of tuned into threat and we want to kind of prevent threat. But, it's useful to sort of understand really how some people, if you're not expecting that or have no kind of forewarning that these kind of thoughts are possible, that would be tricky for lots of people. And of course, going through sleep deprivation is, it's something else as well. So really kind of understanding that context is there, and you're so depleted in all ways really, and how specifically hard that is at that time. I think it was very helpful for me as a therapist and a researcher really to really understand a little bit of what that's like.
Yeah, well, I mean, there's a reason that I contacted you at this particular time is because we've just had our second child together. So just
congratulations.
Thank you. 10 weeks on Sunday, and it's been interesting to see some of the seeds of this kind of thing in myself.
Right.
So, and Leanne, my other half, we were talking about this just the other night, and she was saying that she keeps having this image of dropping the baby, and whenever she's picturing dropping the baby, the baby's always falling to the floor skull first, and the baby's going to smash her head to pieces on the floor, and so she's always whenever she gets up with the baby, whenever she's carrying the baby anywhere, it's really that thought is really at the forefront of her mind, and she's really cognizant of it and trying to behave appropriately, but it's not become, it hasn't spilled over into affecting her life in any way, and she's not questioning herself based on that. For me, not so much with the new baby, because I feel like I'm kind of into the swing of things a bit now. But I do remember when my little boy Roman was born. Oh God, I do things like carrying him down the stairs was real bad. I mean, I always pictured I was going to trip up on the stairs, and then what do you do? Do you try and throw the baby behind you to save it, or do you just hold on to it? And I got to the point a couple of times when, especially if I was carrying him, say early in the morning or late at night, I wasn't quite with it. There's been a couple of occasions where I've slid down the stairs on my ass, just in case. Yeah. And even now, what I do with Hope, when I carry her down the stairs, I make sure I've got this little technique where I scrape my heel down the back of the stair to make sure my full foot lands on each step as I'm going down. I feel very strange around knives and things. So I was in the kitchen the other day, Leanne was cooking, and she's talking and she's waving this big chef's knife about while she's kind of gesturing, and I'm holding the baby, and I'm thinking, God, I mean, she could let go of that, and the baby and the knife could come flying off and stab the baby in the chest.
Right.
What I'm interested in is, do we know what it is that then turns them thoughts for some people into a distressing obsession that they can't let go of? Because in the moment, I don't like that thought, and especially, I'll be honest, and I'm saying this for the people that are listening. I feel it's important with this particular topic to be graphic about the kind of thoughts that people are having, because I wonder if a lot of people listen to a podcast like this, and if you skim over the stuff, people might think, well, yeah, I get that, but I get it way worse than that. So maybe maybe I've got it worse than most people. But my images of harm coming to my children are real graphic. And another one I'll throw out there is, I remember when we was on holiday once. This was when we just had Roman. We went to the top of this lighthouse, and I started thinking. I'll say as well, I struggle with an anxiety disorder, and I kept getting this awful image of, just think I could just pick him up and throw him over the edge of this thing now. Mm-hmm. And I mean, I've got to be honest, Fiona. I feel a bit uncomfortable that I've thrown that out there now, because it's like, you'd never act on it, And obviously I've let that go. It never became a thing. But yeah, going back to that, I'm just wondering, do we know what it is that turns that into something that somebody can't let go of?
Yeah, we definitely have some ideas. So I think, thank you for those descriptions. So it's reassuring. It's quite similar to mine as well. But yeah, these thoughts are really normal, and there's some excellent research asking people about the whole spectrum of them, just going up to people in like a normal sort of weighing clinic, I think, and saying, what thoughts did you have? And people disclose the whole load. Like, I could, drown my baby in the bath, I could push in the fontanelle, and I could sexually abuse them. And I thought, how brilliant that research is out there, and how, must have been very good researchers. They got people to kind of actually say, so we know these thoughts are normal, and these people were, they weren't clinical. So there's something that differentiates, obviously, the people for whom these thoughts, not that they bother most people, but why do they kind of persist? And there's lots of really nice, elegant research showing that if you kind of ask people when they're pregnant about kind of their beliefs about what thoughts mean in the abstract way, are thoughts important? That's a really important kind of predictor about how worrying these thoughts are later. It kind of makes sense, doesn't it? If that's the sort of baseline, if people kind of think, hold certain beliefs about thoughts, and we know that these thoughts are really common after you have a baby. If you then have those thoughts, which you will, you'll be more kind of distressed by them. And it's then you might act differently on the thoughts. So if you think, oh my goodness, that's a sort of weird thought, I don't want to do that, and you kind of just get on with it. If you start thinking, well, what if I could do that? Perhaps I should stand a bit back. Perhaps I shouldn't. Perhaps I should give the baby to my other half. Perhaps I should be a bit careful here, because I've heard about these people kind of going crazy and losing. Perhaps I should stop drinking coffee. Perhaps I should put all my knives away. And you start acting as though this thought does mean something very important about you. You're more likely then to have more of those thoughts. You're more likely to be more worried by them. They're going to kind of persist. You're going to be on the alert for them. And that really is how the problems kind of develop and persist, really. It's the interpretation of the thoughts. It's not having the thoughts in the first place. It's what you then kind of make of them, and it's then what you do about it. So there's a very kind of specific relationship between all the kind of safety behaviours and what you do and what you don't do, that then can make this into a real problem, and you start sort of doubting all sorts of things. So that's we know that the kind of the engine room of OCD really is what you make of these experiences, not whether you have them or not. It's whether you kind of, it feels like it could mean something terrible about you or about what's about to happen, and then people acting accordingly.
Yeah, I suppose that's one of the most important aspects of this is why people should share their experiences, and like I say, and be very kind of graphic and honest about it, because that's going to help people realise how normal it is. Because your immediate thought, think about picking your kid up and lobbing them off the top of a lighthouse when you're just supposed to be having a nice day out in the sunshine with your family. Your immediate thought is, what sort of person thinks like that?
Right.
And it's, I imagine, like I say, I'm not sure quite what it is. Maybe it's because I see humour in my own ridiculous thought patterns. But for somebody that doesn't, and you don't know that other people have those thoughts, it's totally understandable that you possibly think that maybe the seeds of that are in you, and maybe something's growing in you that's malevolent. And
yeah, and I that's absolutely right, I think. And I think when you're becoming a parent, it's all a sort of unknown territory as well. So you're kind of unfolding as in a different chapter, and so it's completely understandable, what you just described, really, that people might think, well, hang on a minute, is this opened up something kind of awful about me? So all these kind of absolutely lovely mums, competent parents, they're absolutely, delightful, worrying about something like being a paedophile, when it really could not be the furthest thing, from who they actually are. How can that worry take hold? And I think that the sort of shame and stigma of having the thoughts and what people feel, others might think of them, and not having sort of knowledge that these kind of thoughts are normal is such a sort of crucial part of the picture. People, it's a very sensitive time, isn't it? You feel like you're being evaluated probably just by the sort of next mum on the bus, let alone by, professionals. So talking about these things can be really, really tricky. So it has been great to see we've made some strides in that there is much more of an awareness that these thoughts are normal, but, things like this and, charities like Maternal OCD, that is really their mission. They're kind of raising awareness. They've got it onto health visitor training. They have a very kind of accessible kind of website and so on. And we just need to kind of get it out there that these thoughts are normal. And that if you're worried about them, that help and treatment is available. It can be really effective too.
One thing I'm interested in is as far as causes are concerned. So I know there's a lot of circumstantial things. I know you were mentioning sleep as well. I interviewed Jason Ellis from Nottingham University a few weeks back, and one thing that he said that stuck with me was that he said we know from research that when sleep begins to fall apart, something wicked this way comes. He said it's a very good loss of sleep is a very good predictor of developing mental health problems. So there's that, of course, with becoming a new mum. There's there's just the stress of it, the circumstance, different lifestyle changes. Another thing that seems to get thrown out, everything gets blamed on hormones. Every problem during pregnancy and afterwards, it's the hormones, which is fine. I understand, especially with things like depression, there can be very like a direct causation there. Do we know if there's the same thing for OCD? Is there a direct correlation between hormonal change and OCD development?
Some people have looked at that and got people to do kind of ratings across the sort of, menstrual cycle and stuff like that to explore that hypothesis. And I think the truth is, there are likely to be subgroups of people for whom, they're very susceptible to hormones, and it's, there might be an indirect sort of impact of mood changes and so on, but it's not causal, because clearly for most people it doesn't play any significant role, and this is why having more literature about the dads who develop OCD as a result of their partner becoming pregnant is a kind of a useful I suppose pinch of salt with that argument, that it's clearly it might play a role for some people, but actually kind of psychological factors, other factors are going to play significant roles too. So yeah, I think it's an interesting idea, but it's unlikely to have massive amounts of explanatory power, I think.
What do you think of the kind of evolutionary psychological perspective of OCD and how much that influences this particular period? And should probably explain exactly what that means as well for the listeners.
Yeah, so the idea that these sort of thoughts have evolved as something helpful, I find that a very persuasive idea, actually, and a useful idea, and a sort of therapeutically it's very useful, and it makes a lot of sense. I think that we have these thoughts in order to warn us of what we don't want to do, in order to help us preserve the species, really. And that's where yours and my experience, I think, really sort of fits in. It's like, why would we have these horrible thoughts? And they make us be a bit more careful, a bit more alert to threat. So there's someone called James Leckman in the States who's big on this and done research with people, non-clinical kind of populations, and that's his big idea that these thoughts are really, really common, particularly in the first kind of 3 months. We're kind of preoccupied with our children, we're kind of harm focused, and it tends to sort of tail off, and that's when they are most kind of vulnerable, I guess, in every sense, from us and from external threats. So I think it does make a lot of sense, and I think it makes sense of why the thoughts are there, but of course it doesn't mean that we can't then kind of do something about those thoughts, change how we feel about them, change how we kind of respond to them. But I think it's a actually a useful part of the picture.
Yeah, well, I think that knowing the evolutionary perspective on it could possibly help somebody distance themselves from the thoughts, in just knowing that. I mean, a concrete example is obviously the mother that worries about dropping the baby on its head, and the mother who doesn't worry at all, doesn't even think or consider dropping the baby on its head. Obviously, the mother that does worry about that, her child is more likely to survive. She's going to do a better job of protecting the child from harm. And because of my own anxiety troubles, I've come to see the brain as like a protective pessimist organ. So if you think like the liver secretes enzymes, your pancreas secretes insulin, your brain secretes pessimistic thoughts. Oh, wouldn't that be terrible? Wouldn't that be horrible if that happened? Oh God, don't do that because X, Y, Z could happen. And it's in doing that your brain putting all these things out there, that instead of trying to think of it as, oh God, because again, these thoughts don't arise voluntarily. They just pop up spontaneously. And so it's possibly being able to just stand back from them and say, well, thanks brain for that image of stabbing my baby to death, but no, I'm not going to do that. So let's kind of move on. I mean, I know it's much easier said than done, but I just think in gaining that perspective on it, in knowing that it's something that happens to you, not that it's something that you're actively doing, I don't know, might just provide that little bit of distance that can get you started on an upward spiral, I suppose. One thing I'm interested in, I suppose, with in reaction to worrying about harming the baby and etc. and contaminating the baby, whether that's going to result in behaviours of the mum not wanting to interact with the baby. So I don't want to touch the baby, I don't want to get the baby covered in germs, or I'm scared I might harm the baby, so hand the baby to the dad or to somebody else. And I'm wondering, whether that's going to have an effect on the bonding that takes place between the mother and the child, and then possible further, do we know if there's further ramifications on the child in its later development?
So I had a little look at this myself. So I think it is certainly possible. Obviously, people are trying to kind of, work around their difficulties, and I think it's, sometimes they can want to take all the responsibility, so actually stop the dads from holding the baby, for example, or not let anything else that's not kind of a known kind of quantity, I suppose, come into the house, and so on. So it can work in that way, or it can be the opposite. Whereas, people are kind of worried about, if I change my baby's nappy, I might kind of hurt them, abuse them, and they try and get somebody else to do all of those things. That's quite difficult to do as well in reality. So it can kind of swing both ways. And obviously, that makes life really kind of tricky. It's hard enough anyway. And I think it's sort of a question about how people manage the sort of competing demands of the disorder and parenting. And I have to say, generally, I think people manage it amazingly and do really, really well. And, what we know about this problem is it's a problem of really caring a lot. It's a problem of, if you could say caring too much when it comes to kids, but, that's what the OCD is kind of harnessing, I think. So it's not about not being bonded. It's about just being so alive to all sorts of threat that it's kind of got you doing all sorts of things which you don't need to be doing. But the actual kind of the bond is there, I think. So when we looked at that in our study with postnatal mums, we found that actually in terms of attachment we looked at, which is the sort of gold standard measure of bonding, that there were absolutely no difference between groups of people who had OCD and who didn't. There was actually the same kind of distribution of attachment categories. And that was a really, really nice finding and good news, because of course that's what lots of people are worried about. But at the same time, mums were saying that, they were not having a good time, and they were exhausted, and the problem was really very demanding of them. And so, of course they needed help and treatment, and they were often very worried about the impact on children. But I think a really a helpful thing was that they, no different from any other parent in terms of kind of how they were with the kids and sort of loving them, and that actually it's helpful in treatment. That there's no benefit to parenting to have this problem. It doesn't make you a better parent, and not having it will make you enjoy parenting more, and that having it kind of doesn't damage your children per se. But of course, everyone is better off without OCD in the home, really. So we did have that finding in relation to the bonding, and I think it's absolutely clear that these were really lovely parents. Everyone has their ups and downs, don't they, and their bad days, and that's okay. A bit, further down the line, we don't know so much, and we know that there are kind of aggregations of anxiety problems that, if you have parents with anxiety problems, you're statistically more likely to get those difficulties. And we need to sort of understand a bit more about that and how we can better help parents, with the things that we can do. None of us can do anything about our anxiety levels when we were pregnant or any of that stuff. But there are things that we can all do. Actually, it's not just specific to parents with anxiety, but to be kind of better parents and reinforce the right things and so on. And things that might kind of challenge more if it kind of goes against your own fears. For example, if you've got social anxiety, getting your child out to sort of play groups and so on is going to probably push your buttons, but it's going to be equally important for your child and the next child to go to those things and so on. So I think there might be, and there's likely we can do a lot more to help parents as their children get older and to help them confront their own fears and confront the fears that kind of can get in the way of things. So there's a very long answer for you there. Does that answer the question?
Yeah. No, of course. Right, okay. So I guess the next thing is seeking treatment is the obvious thing to do. Now, I suppose rather than go... Well, firstly, let's say something about it. Not the techniques and things like that, but if you can just speak on the effectiveness of CBT for people that, I run into still a lot of people that maybe think it's a bit of a fad or it's not going to help. So if you can just speak on that, and then I've got a question very much related to that. So,
there is loads of evidence that CBT is effective, probably for 2/3 of people that do it. This is the general kind of evidence. And it can be effective in a really short timescale. I did a treatment trial, so in the study I'm talking about, for mums with postnatal OCD, and that showed very effective treatments as well. So it was an intensive version of CBT. So it's definitely worth a go. Most people get some benefit, if not completely better. Lots of people do get completely better as well. So, there's a reason why everyone's offered CBT. It's not a fad. It's been, this has been sort of carefully documented in treatment randomized trials over the last kind of 20 years. So it's the best that we've got. No treatment is perfect. It does, to some extent, you get out what you put into it, I would say. And that might be lots of things, reasons why it might be difficult to kind of fully commit to it for all sorts of reasons. It might be that, it's not quite the right therapist, or it might be that, you've got a lot of other stuff going on in your life and so on. But it's an individualized therapy. And I think it can definitely work brilliantly. You can get your life back from this problem. Doesn't make it life perfect across the board, but you can make significant gains. And it's a form of self-help, is the way we always kind of describe it. It's about learning tools, getting knowledge about your own problem and doing things differently, testing things out. It's a really active treatment. And it puts you in the driving seat, really. Your therapist is there to sort of help and guide you, but it's not something that's done to you. It's something that you kind of do yourself and do with your therapist. So I would definitely strongly encourage people to give it a go, and ask the questions of your therapist. If you've got that skepticism, I welcome it. I want people to be skeptics within treatment. I want people to not take my word for it. I want people to kind of, engage with it and say, yes, you're saying that, and and us going, well, how can we test this out then? And that's where people get the benefit from really kind of going for it. I think if the conditions are right and you got a good therapist, it really is, it can work wonders. That's a bad phrase to use, I suppose, because it's not it's not magic. It is very much about kind of it making sense, and if it doesn't make sense, ask questions, bring along notes, challenge your therapist, and that's what we like. Is how it works best.
Yeah, I mean, if you any mums out there listening to this feel like this is what they're going through, if you look at any of the blog posts and then the news articles on women that have written about this with lived experience, it's CBT is the thing that seems to have helped most people through it. However, and I talked about this with Paul in the episode on OCD specifically, but I think it's worth raising again here. How the hell is a mum supposed to approach somebody and, like, okay, where do you get started with telling somebody about this? I mean, it's one thing, like I've just said, it's a little bit uncomfortable for me to share those thoughts, even though it didn't develop into anything like OCD. Yeah. And I know when I'm editing this episode, I'm going to second guess myself as to whether I include certain things. I will do. I won't edit anything out, but that's just my very basic, what you could consider an almost untroubling experience. But if there's a mum out there who's, say if her obsession is something like stabbing the baby or sexually molesting the baby, how do you get started with being able to tell somebody that? I mean, I just think the last person you want to go tell is your GP that I'm thinking I'm having thoughts about molesting my child, because I mean, the consequences of that, if it's misinterpreted, could be so bad. So what would your advice be to a mum that's maybe listening to this and thinking, like we all do, like, yeah, that's me, but mine's way worse than anybody else's?
That's a really common thought as well. Yeah, I mean, I think you're raising some very important issues. I think if it resonates with you listening to this, go and have a look at the sort of criteria for OCD, and then go armed with those when you're going to seek help. Say, I think this is OCD. I'm having unwanted thoughts. I'd rather not go into exactly what they are, but I know I won't act on them. That fits with the diagnosis of OCD. I'd like to refer me for an assessment, and kind of that's generally probably the way to go. I don't think you need to disclose everything to everybody. Trust is something that needs to be earned, and if you feel like you're in the right environment, people understand about the problem, then that's the right environment to give the details. But if you're unsure, I think it's fine to kind of to be cautious in those interactions. But the more you can get information yourself, looking at Maternal OCD website, OCD Action, OCD UK, they have good sort of guides as to how to approach help as well. But if say I think it's this, can you refer me to a specialist for an assessment? That would be my kind of advice for approaching that. You do get GPs who are knowledgeable about it, but you'll get a sense of that when you go in. I think that the function of that appointment is to get you referred to where you can get sort of active help. So sort of keep that in mind. Not everybody does need to know everything. Yeah.
So when you go to see the GP, makes perfect sense. You can hold back and you can approach it with caution. Would you say that when you find a CBT therapist, and again, you can do the same with your therapist, you can test them, see whether you click with them, is this person right for me? When you find the therapist that you feel is the right therapist, would you then advise that it's then perfectly safe and also probably more helpful to be completely open about the content of the disorder?
Yeah, absolutely. As far as you can, but I think that's also the therapist's job to create that environment and earn your trust. And give the, examples that they do understand that these thoughts are normal, that lots of people have them, even the really dark ones, the ones that you're thinking, yeah, okay, that one and that one, but my one is bad. And you need a therapist to go first to explain that. And I think if you've got that, then absolutely, because the disorder, it loves secrecy. It loves that idea that, okay, this therapist knows about this, and you can deal with these forms of OCD, but that other thought that you had, maybe that's not OCD. And it's even okay to tell your therapist, look, there is something I'm holding back, and then you can discuss around it. And it's that's our job. That's the therapist's job to think about what the OCD is telling you about that thought. Why is that thought different? How does that work? What might be the benefits of disclosing it? Because if you sort of hold bits back, then OCD, I think, loves that. It's kind of keeping the idea of the what ifs, and the best way forward is to kind of embrace it and go for it and leave no stone unturned. And that's what takes the power away from the OCD. You can have any thought going through your mind. You can write any thought on a piece of paper. I can't tell you the number of times I have written, I am a paedophile, and wished death on everybody I know. So far, everyone's okay. And it's not a comfortable thing to do. But as a therapist, I've got to be comfortable with going there. And I've got to show that I have total confidence that thoughts are thoughts, words are words. And it's up to me to kind of do that and demonstrate that, so that my clients can feel comfortable, disclosing what's on their mind. So it's a shared responsibility for that, I think.
Okay, great. Okay, Fiona, before I let you go, I'm going to subject you to my quickfire questions, if that's okay with you.
Okay.
Firstly, do you have any book recommendations on this topic or anything else that you feel would be of value to the listeners?
Well, it's wrong to blow your own trumpet, but we do have a book that I wrote with Paul, I have to say, Break Free from OCD. And they did ask us to write it with, how we do therapy in mind. So we have had good feedback on that. It gives a heads up for therapy. And there's lots of stuff about mums in there and parents' thoughts as well. The Overcoming OCD book is really good too. There is also a book on compassionate mind approaches to postnatal depression. So that's quite kind of nice. That covers intrusive thoughts as well. So those would be the ones.
Yeah, The Overcoming, is that David Veal?
That's David Veal's.
Yeah, I've read. I know this is probably going to sound like bollocks to the listeners, but both your book with Paul and David's book, I've read both of them. Read both of them when I was doing the research to interview Paul in the first place. Brilliant introductions, and I highly recommend them to anybody. Okay.
Thank you.
If you could have unlimited funding to research anything you liked, however niche or bizarre, what would it be and why?
I'm really interested, in making treatments more effective. So if I had unlimited funding, I would look at whether we can do kind of faster treatments. I would want to spend a bit more time looking at people who didn't respond to treatment as well, and kind of being able to keep people engaged and in treatment, to be able to sort of work out what it is that they're sort of getting from it. So doing lots more sort of qualitative work on that. And also really interested in relapse as well. So quite often, people do really well in treatment and they'll be really good for a few years, and working out actually how can we sustain that improvement. And sometimes, things happen in life and so on. But I'd love to do more research on kind of earlier intervention, I think, across the board. So where people have had good treatment, it's worked, and they're starting to relapse, and where also, we can get in with more kind of preventative interventions as well. So so kind of a range of things, better, more effective treatments. We know we've got a good thing, but it doesn't work for everybody. Why is that? And it doesn't work in a totally sustained way for everybody. And of course, the I don't know what the word, the holy grail is prevention, really. Is there more that we can do? Because lots of people, I think, develop problems during adolescence. Most problems have emerged by adolescence for most people in terms of, the whole mental health spectrum. So clearly we should be targeting a bit more effort there in terms of identifying people and getting treatment to people sooner. We don't want people to have sort of years of life where they're sort of processing this and what's going on. So yeah, that's a programme grant for you there.
Well, it might be a bit of crossover with this answer, but yeah, if you could take the reins of power at the Department of Health, what policy would you implement to improve the mental well-being of the general public?
From the Department of Health.
And think very dictatorial, like you can do anything.
Oh, this is a good one. I think, yeah, having probably more accessible therapy and longer term therapy, I think, as well. I think, so much of the difficulties that we have in mental health are in some way to do with, I think, relationships. And then as services, we're kind of mirroring these very abrupt relationships and kind of, there's so many people, I think, that I've worked with. And I think, that if we had a better model of service, we could really, because it would answer some of the other questions, we could keep people weller, I think. We come into their lives and get them to talk about all sorts of things, and then we kind of leave them, I think. So I think having models of the service where we can actually look after people better, I think having, more accessible services for everything. So not necessarily people have to be right at, at rock bottom, but actually where, services where people could go in for kind of, boosters or, other sorts of skills. So I'd put more into that, I think.
What, if anything, keeps you up at night?
Many things apart from the children. I do kind of worry about the defunding of services now and how much pressure the people I'm seeing are under from, changes of benefit rules, how stressful that is. Some people will worry about that for like half a year in advance of it. And it sometimes feels like, although, we are doing our best, there are some more sort of fundamental things in society that could just give people a better baseline for doing some therapeutic work. So yeah, I can't help but worry about the people where I feel, things could be better for them. That does come into my mind a lot.
Right. Final 5, and these are the profound ones now.
Oh, these are the profound ones. Blimey.
Yeah. Oh, we get a little bit deeper as we go along. Okay. What's the best piece of life advice anyone's ever given you?
Enjoy the process, I think. That, you do all these things and you think, oh, maybe that they're kind of a means to the end, but actually each day of your life is where you're at right now. Enjoy the process.
Totally agree. What mistakes do you continue to make despite knowing better?
I take too much on and I say yes to too many things, and I don't look after myself sometimes. So I could practice what I preach a bit better. Sure. What
part of your career are you most proud of?
I'm really proud of my work with the mums, which was my PhD study. And it was a long haul, but I got to do lots of treatment within it. So I felt it was really sort of sustaining that this was a new area and that we were kind of going to learn something. But I also got the benefit of actually helping people on a very direct basis. So there was the project, and they were amazing for taking part. And I put them through all sorts of, lengthy assessments and everything. And so I feel really proud and kind of grateful to have that as a part of my life, really. And I'm still in contact with many of those lovely mums as well. So yeah, I feel like the fact that we're talking about it now, it's having some kind of impact. So that makes me feel very happy.
Outside of family and academia, what investment of time or money has brought you the most joy or fulfillment?
I do a lot of singing. That's the thing that I do, sort of music. And
what sort of singing?
Choral singing. So yeah, sort of English choir sort of traditions, that kind of stuff. Yeah, classical singing. I love that. I've had some really amazing experiences kind of performing and with some really excellent people. And it's, you get that emotional stimulation, intellectual stimulation, and creating something. That's pretty special.
Okay, and last but by no means least, what do you think is the key to happiness?
That's a big question. Probably, well, just accepting who you are, being happy with, what you've got, and enjoying what's around you. I think that's not too kind of banal an answer, but kind of really taking time just to sort of smell the roses, I suppose.
Okay. Fiona, is there any links you'd like to recommend the listeners pay a visit to? And also, if you're on social media?
I would recommend going to the Maternal OCD website, which they're updating at the moment, but we'll have all sorts of information relevant to this, adding over the sort of coming months. And OCD Action, OCD UK. I am on social media. I'm Dr. Fiona Cha on Twitter. But I will warn you will also get sort of random messages about cricket and goodness knows what, and concerts probably. So, but I am on there if anyone's interested.
Well, that's fine. I'll include all the links in the show notes. Fiona Challacombe, thank you very much.
Thanks so much for having me.
Okay, folks, if you enjoyed this episode and you've got a couple of minutes to spare, then maybe you'd consider leaving us a positive review on iTunes or Stitcher or whichever podcast service you happen to use. That'd be greatly appreciated. It also encourages other people to give us a listen. If you can't spare a couple of minutes, but you've got a couple of seconds, maybe you could share one of our episodes with your family or friends on social media. Don't forget you can comment on any of these episodes by going to myownworstenemy.org/podcast. And if you'd like to contact me, you can email me at danny@myownworstenemy.org. Or if email's a bit old-fashioned for you, then you can get hold of me on all the different social media channels at Danny D. Whitaker. And that's about that. I'll see you again next time.